Hey guys, good morning. This is Mr. Alberto Verdad, and I hope you're all doing well. Um, I was trying to look for ways of how I can probably help you guys with your NCLEX review, and of course, uh, giving you some materials that you can probably review whenever you want or wherever you want. So I came up with this idea to to post some short videos online on my YouTube channel, and I'm planning to post a video every day so that at least we can talk about different concepts or different conditions related to medical surgical nursing, and hopefully at the end we can talk about some questions that you might encounter in NCLEX related to this particular topic. So anyway, for this morning I decided to start with the endocrine system. And what will happen is um, I will probably dissect the endocrine system and the endocrine disorders into um, several, topics, just to make sure that we can cover everything, and that you know we will be able to dissect each disorders properly. So anyway, so today just for the introduction, let's go over the endocrine system again. And I'd like to use anatomy and physiology as a springboard for discussion. um, I believe that if we know the normal anatomy and physiology, then it will be easier for us to understand deviation from normal. So, all right, so let's talk about this endocrine system. And when we say endocrine system, there are basically um, two types of glands that we have in the body. When we say endocrine system, then we're talking about glands, and we're talking about hormones. But before we talk deeper on those hormones and functions of these glands, let's differentiate exocrine glands versus an endocrine gland. What's the difference between an exocrine and an endocrine gland? Well, an exocrine glands are glands whose secretions pass into a system of ducts that lead ultimately to the exterior of the body, meaning exocrine glands uses channels or ducts in order to secrete their secretions, and a lot of times their impact to the body will be local, and ultimately their secretions will be coming out of the body. A good example of this would be sweat glands. Sweat glands uses ducts in order to release sweat, and ultimately this sweat will be coming out of the body. Another good example of that would be pancreatic juices secreted by the pancreas, like your amylases and lipases, and that helps in the digestion of food. And these secretions will ultimately come out of the body through the GI tract. Um, However, endocrine glands are composed of glands that doesn't use ducts in order to secrete their secretions. They are sometimes called ductless glands because their secretions will be secreted directly into the bloodstream, and their impact to the body will be systemic. And of course, they're using hormones, again, that can be released directly into the bloodstream, causing a systemic impact or a systemic effect. So let's look at some of the organs or glands rather associated with the endocrine system. Number one, we have the hypothalamus right here. Hypothalamus has many functions, not just the endocrine functions, but it controls the body temperature as well. The water holding mechanism is also controlled by the hypothalamus. We also have the pineal body or the pineal gland, and the pineal gland right here is an important gland in regulating our sleep wakefulness pattern, our diurnal pattern. The pineal gland or the pineal body releases a hormone called melatonin, and melatonin actually regulates your body clock, so to speak. This is the reason why some people, I don't know if you have some or if you notice this among older people. Sometimes, older people, it doesn't matter what time they go to bed at night, they will wake up at certain time early in the morning, and simply because it's how their body regulates their pattern, or the pineal body rather regulates their wakefulness pattern. Another important part of the endocrine system is your pituitary or the pituitary gland. The pituitary gland is actually resting right beneath the anterior lobe of the brain in um, in a hollow portion of the skull called the sella turcica. Pituitary gland is sometimes called hypophysis, and it has two lobes, an anterior lobe, which is glandular in nature, and a posterior lobe, which is basically controlled by the neural system. So it's neural in nature. Um, then we also have the thyroid gland. The thyroid gland is a butterfly-shaped gland that hugs your trachea, and the thyroid gland releases three hormones, your T3, your T4, and of course the calcitonin. Behind the thyroid gland, you have the parathyroid gland. Some people will, or most people will have four small parathyroid gland located posteriorly or at the back of the thyroid. Some may even have six. The parathyroid gland actually helps in regulating calcium from the body or from the blood, and it helps in maintaining the balance between serum calcium and, of course, calcium that can be deposited in our bones. So it kind of help serum calcium or the secretion or the level rather of serum calcium, of course, with the help of calcitonin secreted by the thyroid gland as well. The thymus is another gland located behind the sternum, and the thymus actually regulates the body temperature among babies. So when you were younger, the thymus helps regulate the body temperature. But as you grow older, the thymus starts to shrink, and during adult life, the thymus will serve as the training ground for your T lymphocytes, maintaining good immune system as well. So again, like I said, the thymus regulates the body temperature during infant life. But as you grow older, the thymus starts to shrink, and the regulation of the body temperature will be transferred to your hypothalamus. Um, Another important gland of the endocrine system are the adrenals, or the adrenal gland, or sometimes called the suprarenal gland. Why suprarenal? Because they lie or they sit on top of the kidneys. So supra meaning above. The adrenal glands has two layers. You have an inner layer called the medulla, and the outer layer called The cortex. The cortex releases three hormones. We sometimes call them the triple S for the sugar, the salt, and the sex hormone. The sugar being your glucocorticoids, and the salt being your aldosterone that helps in the reabsorption of sodium. And of course, you have the sex hormones, your androgens. The islet of Langerhans in pancreas is also considered part of the endocrine system. By the way, the pancreas is the only gland in our body that serves both endocrine system and the exocrine system. The amylases and the lipases released by the pancreas during metabolic process are part of the exocrine function of the pancreas, whereas the release of insulin from the islets of Langerhans, particularly the beta cells, is part of the endocrine function of the pancreas. The alpha cells in the islets of Langerhans is also part of the endocrine system because they are the ones releasing a hormone called glucagon that helps in the regulation of blood sugar in case of emergency or during stress response. Then we have the gonads, the ovaries for the female, and of course the testicles or the testis for the male. The gonads releases what we call gonadotropic hormones, particularly your follicle stimulating hormone and the luteinizing hormone. We'll talk about that in details later, but let me just continue with this. So, our endocrine system can actually help in maintaining homeostasis of the body, in maintaining the normal internal milieu. And there are three ways where the endocrine system can actually help in maintaining an internal balance. Number one, there is what we call a hormonal response coming from the endocrine system. And the hormonal response simply means that in order to maintain homeostasis and maintain internal balance, then the endocrine system will release hormones that can trigger the release of other hormones in order to keep that internal milieu or internal balance or homeostasis, so to speak. So a good example of this would be, let's say, for example, the T3 and T4 is getting low and there's not enough energy of the body, then the hypothalamus will help trigger the release of hormones from anterior pituitary gland. So hypothalamus will be releasing some hormones that will trigger the anterior pituitary gland to release other hormones, creating a domino effect. And these hormones can target several organs or several glands of the endocrine system, like the thyroid gland. And once a hormone from anterior pituitary, like for instance a thyroid stimulating hormone, is released, then it will trigger the thyroid gland to release other hormones, particularly T3 and T4. And it's the same way with the adrenal cortex. Again, like I said, if you remember, I mentioned that the adrenal cortex or the suprarenal gland has two layers. It has an inner layer called the medulla, and it has an outer layer called the cortex. Now, when anterior pituitary gland releases a hormone called ACTH or adrenocorticotropic hormone, that hormone can actually trigger the adrenal cortex to release the adrenal cortex hormones, which is what we call the triple S, the mineralocorticoids or the aldosterone, the glucocorticoids or the cortisol, and of course your sex hormones or the androgens. The same way with the gonads, the testicles, some gonadotropic hormones can be released by the uh, anterior pituitary gland that can trigger the gonads to release some hormones that will help in maturation of spermatozoa. and like the luteinizing hormone and the follicle stimulating hormone. Another way of maintaining internal balance handled by the endocrine system is a humoral response. When you say humor, um, it's a Latin term that refers to fluid. So when you say humoral response, it means it's a fluid response. So it's in the blood. Um, this is basically a response of the body regulated by what we call a negative biofeedback mechanism, meaning if there is something lacking in the blood, then a particular hormone will be released in order to maintain a normal level of such of whatever hormone is lacking or whatever minerals or electrolyte is lacking. Like for instance, if there is if there's a decrease in capillary calcium level, like if the patient's having a little bit of hypocalcemia, um, hypocalcemia meaning patients having a little bit low in calcium, causing some signs and symptoms like trousseau sign or maybe tremors or tingling sensation or shibastic sign. What will happen is this low capillary calcium level in the blood can be sensed by the parathyroid gland, again located posteriorly or at the back of the thyroid gland. And this parathyroid gland will be triggered to release parathormone or parathyroid hormone that can actually help mobilize some calcium from the bones, and it will bring those calcium back to the blood. So it's a good way of check and balance. Calcitonin released by your thyroid gland can actually move calcium from the blood to the bones, whereas the parathormone or the parathyroid hormone can actually mobilize calcium from the bones and bring it back to the blood in order to maintain a normal calcium level and preventing complications such as hypo or hypercalcemia. The third regulation or response coming from the endocrine system, and sometimes with the help of the neural system as well, is what we call a neural response. And a lot of these neural response are designed to protect the body, like in terms of stress or in terms of danger. These responses will be activated, and in order to protect, again, the internal balance and protect the body itself. Like in case of the fight or flight response, in case of stress, what will happen is the central nervous system, particularly the preganglionic sympathetic nervous system in the spinal cord will be triggered to stimulate the adrenal medulla, and the adrenal medulla will release what we call catecholamines, and these catecholamines are your epinephrine and norepinephrine, and this will help the release of epinephrine and norepinephrine will help the body in terms of getting more energy if you need an extra energy in terms of stress. And that's also the reason why during stress we have so much energy coming from the inside of the body because of these responses. How many times have you heard of a situation where a regular guy can carry a refrigerator from the kitchen out to the backyard in case of fire. But as this guy to bring that refrigerator back to the kitchen after the fire, then he won't be able to do that. Of course, I'm exaggerating a little, but what I'm trying to say is that, in case of emergency, in case of stress, then we have so much extra energy that we can utilize in order to handle the task at hand, and this is partly the result of stimulation coming from the central nervous system, stimulating the adrenal medulla to release massive amount of catecholamines during that time. Okay, so um, the pituitary gland, which is sometimes called hypophysis, is actually considered as the master endocrine gland. And you might say, well, how come pituitary gland is considered as the master endocrine gland, but the pituitary gland is also relying on the stimulation coming from the hypothalamus? That's true. The release of hormones from the pituitary gland is, in most cases, triggered by hormones coming from the hypothalamus. The problem is the hypothalamus serves many functions like water holding mechanism regulation, body temperature regulation, and there's a lot more that hypothalamus does, um, that has nothing to do with the endocrine function. So just to uh, just to be clear, the pituitary gland uh, mainly serve the endocrine system, and it only affects all those glands releasing hormones, which is part, of course, of the endocrine system. Now, the pituitary gland, again, like I said, sometimes is called hypophysis, and it is secured in a hollow portion of the skull right beneath the anterior pituitary gland called the sella turcica. And it has two lobes actually, a posterior lobe which is neural in nature, I mentioned that earlier. And that's why the posterior lobe of the pituitary gland is sometimes called neurohypophysis, being stimulated by the neural system or the neural cells, whereas the anterior lobe of the pituitary gland is basically glandular in nature, and that's why sometimes it is called adenohypophysis. So adenohypophysis for the anterior pituitary and neurohypophysis for the posterior pituitary. Now, if NCLEX asks you, or if you encounter a term in NCLEX that says hypothesis, then it means they're talking about the entire pituitary gland. Now, the anterior pituitary gland releases hormones that can actually trigger the release of hormones coming from other target glands. Um, I have one, two, three, four, five, six actually, six hormones um, in this illustration. Six hormones causing the release of other hormones from target glands or target organs. But in reality, there are seven hormones that anterior pituitary gland releases, and I will explain that later. So let's dissect this one by one. What are the hormones released by the anterior pituitary gland? Number one, let's talk about the growth hormone. The growth hormone, or sometimes called somatotropin, um, or somatostatin. Somatostatin, somatotropin, growth hormone, don't worry about the terminologies. They're all the same. It's the same banana. So when you say growth hormone, somatotropin, somatostatin, the target organs will be the skeletal muscles and, of course, the long bones. They were saying that the growth hormone, usually released early in the morning, will cause elongation of the long bones. And if you remember anatomy and physiology, the uh, long bones, they have two parts. You have the shaft, or the middle portion of the bones, and you have the epiphysis, which is, of course, at the end of the long bones. The shaft is usually composed of compact bones or compacted bones, whereas the end portion, the epiphysis, are composed of spongy bones. And that spongy areas or spongy sites of epiphysis has a little plate or a line. They call it epiphyseal line or epiphyseal plate. And when this epiphyseal plate closes, then the bone or the long bone stops growing. When epiphyseal plates are still open, then you can still have, growth of the long bones. So if we have, let's say, for example, if we have oversecretion of somatotropin or somatostatin or growth hormone before the closure of epiphyseal line or epiphyseal plate, then it can lead to too much growth of the long bones, and it can lead to a condition called gigantism. Now, if we have undersecretion of growth hormone before the closure of epiphyseal line or epiphyseal plate, then what will happen is less amount of growth hormone will mean that your long bones will not grow that much, and it will stay, short, and it can lead to a condition called cuteness or dwarfism. Um, Now, if you have oversecretion of the growth hormone after the closure of epiphyseal line or epiphyseal plate, then this is what they call, or this can lead to a condition called acromegaly. And acromegaly will cause, growth of bones horizontally instead of, vertically. um, and a lot of times you will see patients with acromegaly having really big hands, big forehead, they have big jaw. It can affect the heart as well. um, there was an actor, a famous actor back in, I want to say, early 70s. And he used to be a wrestler too. Andre the Giant. If you're familiar with the movie The Princess Bride, he was one of the actor there, and Andre the Giant actually had acromegaly, and in fact he died of complications from acromegaly. Anyway, another hormone released by the anterior pituitary gland is prolactin, and prolactin actually targets the mammary gland, and prolactin helps in the production of milk. Prolactin helps in the um, hyperplasia of the acini cells of the mammary gland. And when you say hyperplasia, it means an increase in the number of cells. So during pregnancy, in anticipation for the coming baby, then the prolactin will be released in order to multiply or to increase the number of cells in the mammary gland, so that the mammary gland will be able to produce enough milk to feed the baby. Now, oversecretion of prolactin can cause some issues. Like for instance, if the patient develops some kind of a pituitary tumor that causes uh, increased release of prolactin, then what will happen is some women can produce milk even when they're not pregnant, a condition called galactorrhea, and it can happen among males as well. Now, if you have undersecretion of prolactin, then you won't be able to produce adequate amount of milk even when you're pregnant, and so that can lead to a starving baby. Um, so those are some of the issues associated with prolactin, and of course, not just for the mammary gland, but it can alter the secretion of other hormones as well. The follicle stimulating hormone and the luteinizing hormone, these are sometimes called gonadotropic hormone or hormones because the target organ will be, or the target organs will be the testicles for the male and the ovaries for the female. The follicle stimulating hormone helps the female produce more um, oocytes, so it helps in the production of new egg cells. Um, and so it can actually affect fertility of a woman if she doesn't have enough secretion of follicle stimulating hormone. The luteinizing hormone is the one that helps prepare, you know, this oocyte into and help the oocyte towards maturation so it can be ready for fertilization. Um, you know, um, every during ovulation, an oocyte will come out of the ovary, and that oocyte will be waiting for Mr. Sperm in the distal third of the fallopian tube for 24 hours. If Mr. Sperm failed to meet Miss Ovum or Miss Oocyte within 24 hours, then what will happen? This oocyte or the egg cell will die, and the entire kingdom will cry, and you will need to go to CVS or Walgreens to buy whatever it is that you're using for your monthly period. Now, same thing for the testicles. The follicle stimulating hormone helps in production of matured spermatozoa, and it helps in producing more spermatozoa that has the capability to penetrate the thick membrane of the oocyte or the egg cell. Um, called hyaluronidase. The luteinizing hormone for the testicle helps build stamina for so to speak for the sperm cell so that this sperm cell can actually swim upriver or upstream, because remember that sperm must swim from the vaginal canal all the way up to the third part, or the third portion of the, or the distal third rather, of the fallopian tube, just to meet Miss ovum, so that there will be fertilization. So these luteinizing hormone, follicle stimulating hormones are really pivotal in maintaining fertility both for female and the male. And any decrease in the secretion of these hormones can lead to what we call infertility. Um, the other hormone released by anterior pituitary gland would be your thyrotropic hormone, or TSH, sometimes called thyroid stimulating hormone. And as the word implies, the target organ would be the thyroid gland. The thyroid gland releases three hormones, T3, or sometimes called triiodothyronine. We have T4, or sometimes called thyroxine. And of course, we have the calcitonin that helps in regulating calcium level in the blood. Too much secretion of TSH can lead to an increase in the level of T3 and T4 in the blood, and of course calcitonin as well, that can lead to hypocalcemia. Too much secretion of TSH leading to increased T3 and T4 can lead to hyperactivity of the thyroid gland that can sometimes cause what we call hyperthyroidism. On the other hand, undersecretion of TSH will lead to undersecretion of T3 and T4 that will have a deleterious impact on the metabolic process of the body, and that can lead to what we call hypothyroidism. So we'll talk about those details later. The other hormone is what we call ACTH, adrenocorticotropic hormone. The target organ is the adrenal cortex. And I'd like to emphasize this ACTH only stimulates the adrenal cortex, not the adrenal medulla, because the adrenal medulla is triggered by the neural response coming from the central nervous system. So ACTH causes the release of three hormones coming from the adrenal cortex. The mineralocorticoids, sometimes called aldosterone, which is what we consider the salt. The glucocorticoids, sometimes called cortisol. This is what we consider the sugar. And of course, the sex hormones, the androgens. Um, and that's why we have this triple S, the salt, the sugar, and the sex hormones. So far we have identified six hormones coming from the anterior pituitary: the somatotropin, somatostatin, or the growth hormone; the prolactin, target organ, the mammary gland; we have the follicle stimulating hormone, the luteinizing hormone; and then of course we have the thyroid stimulating hormone and ACTH. So that's one, two, three, four, five, six. I told you earlier there are seven hormones released by the anterior pituitary, and what's missing here is your MSH, or the melanocyte stimulating hormone. Melanocyte stimulating hormone actually targets the melanocyte cells under your skin, and oversecretion of melanocyte stimulating hormone, or MSH, can lead to darkening of the skin. Of course, it's affected by exposure to UVR as well. But again, too much secretion of MSH can lead to a darker skin, and under secretion can lead to paler skin. Um, if you heard, I'm sure you're familiar with a condition called albinism, and albinism, where the patient doesn't have enough sorry, pigment on their skin, is usually caused by undersecretion or no secretion of the melanocyte stimulating hormone from the anterior pituitary gland. So again, seven hormones from the anterior pituitary: somatotropin or somatostatin. We have, which is sometimes called the growth hormone as well; prolactin, follicle stimulating hormone; luteinizing hormone. And remember, these two are sometimes called gonadotropic hormone. Or we have thyroid stimulating hormone or thyrotropic hormone; adrenocorticotropic hormone, target organ will be the adrenal cortex; and the MSH, or the melanocyte stimulating hormone. So seven hormones secreted by anterior pituitary gland. Well, Mr. Verdad, how about the posterior pituitary? The posterior pituitary secretes two hormones, just two. One is called the antidiuretic hormone, and antidiuretic hormone helps in regulating water or urine output of an individual. Um, and antidiuretic hormone is sometimes called as vasopressin. And of course, we have oxytocin, which is sometimes called the love hormone. While oxytocin usually is released when you feel comfortable, when you feel love, like a simple hug, a kiss, an act of passion. Um, During sexual coitus, oxytocin will be released, and during labor and delivery, oxytocin will be released as well. So, seven hormones from anterior pituitary, two hormones coming from posterior pituitary. Um, so again, I told you earlier, the adrenal gland can respond to stressors using either the endocrine system or the response coming from the sympathetic nervous system, stimulating the release of epinephrine or epinephrine from adrenal medulla. So if a body is under stress, the, bo- sorry, the body will usually respond by triggering this fight or flight response. And that's how we normally call it, but it's actually the LAS and the GAS, the local adaptation syndrome and the general adaptation syndrome. This response is actually first identified by a guy named Hans Sully, and he was the one who said that our body during stress will have two responses, either by a local response or a general adaptation response. And this responses coming from adrenal medulla and adrenal cortex are what we call general adaptation response. So during stress, nerve cells can trigger the dorsal horn of the spinal cord to stimulate the adrenal medulla, releasing epinephrine and norepinephrine. And when epinephrine and norepinephrine are released, glycogen will be broken down into glucose. Remember, I told you about glucagon, sorry, coming from the alpha cells of the islets of Langerhans of the pancreas, can help in what we call glycogenolysis, or the breakdown of stored glycogen from the liver and the muscles. And it will be broken down into simple sugar, so it can be utilized by the cells for energy, and that can lead to an increased blood glucose level. Epinephrine and norepinephrine, these catecholamines, also causes constriction of peripheral blood vessels that can lead to an increased blood pressure. And of course, if you increase the blood pressure as a biofeedback mechanism response of the body, all of your vital signs will increase as well. An increase in blood pressure means an increase in the heart rate as a response of the heart to a decrease stroke volume. And so, if you decrease or if you constrict the blood vessels, it will lead to narrowing of the blood vessels, leading to a decrease in the stroke volume. So, in order to compensate, the heart will start beating faster in order to maintain a normal cardiac output. Also, in response to that, the respiratory rate will increase in an attempt of the body to deliver more oxygen to the different parts of the body or to the cells. You will have the increased basal metabolic rate. Uh, I'm sorry. Um, Blood flow will be directed towards the central circulation, sacrificing some of the peripheral circulation. And it has something to do again with the constriction of the peripheral blood vessels. On the other hand, the endocrine system will respond on its own by releasing several hormones coming from anterior pituitary, particularly ACTH, or adrenocorticotropic hormone. The adrenocorticotropic hormone that will trigger the adrenal cortex will release two main hormones of the adrenal cortex, the mineralocorticoids, or sometimes called aldosterone, and the glucocorticoids, sometimes known as cortisol. Aldosterone will help in reabsorbing sodium from the tubules of the kidneys. And if you retain sodium or reabsorb sodium, then you will be retaining water that can lead to a decreased urine output and increase in blood volume, and of course increase in blood pressure. So remember that um, these responses will be coming from different stimulation, one from the sympathetic nervous system stimulation and the other one from the endocrine system stimulation. But both will cause an increase in blood volume and obviously an increase in blood pressure. One will be causing an increase in the blood pressure due to vasoconstriction, secondary to the release of epinephrine and norepinephrine, and the other one will also cause an increase in the blood pressure by decreasing the urine output and retaining water by reabsorbing sodium. Glucocorticoids will also help in increasing the blood sugar because glucocorticoids will cause an increased breakdown of proteins and fats, and it will be converted into glucose. This process is what we call gluconeogenesis. So gluconeogenesis coming from the adrenal cortex and glycogenolysis coming from the adrenal medulla will both cause an increased blood sugar, and that's the reason why during stress our body has too much sugar that we can use for cellular metabolism or for extra energy. And this is also the reason why they were saying that um, if we are under stress most of the time, then we have two main problems. It can cause an increase in the blood pressure, which can lead to hypertension, and of course, it can lead to accumulation of too much sugar in the blood or glucose in the blood because of glycogenolysis and gluconeogenesis. Um, the posterior pituitary gland, again, like I said, secretes two hormones, the antidiuretic hormones, sometimes called the vasopressin. The target organ will be the kidney tubules. And too much secretion of antidiuretic hormone will lead, as the word implies, antidiuretic hormone. So if you have too much secretion of antidiuretic hormone, then it means that the patient will not pee, or at least the patient will not pee a lot. Water will be reabsorbed, less urine output will happen, and the urine will become more concentrated, causing an increase in a specific gravity of urine more than 1.025. Remember, the urine specific gravity is between 1.010 to 1.025. So an increase in antidiuretic hormone will cause oliguria and an increased specific gravity, and at the same time the patient will be susceptible to edema because of water reabsorption. It will also cause dilution of the blood because water will be retained, so it can lead to what we call hemodilution that can lead to hyponatremia secondary to dilutional hyponatremia because the blood will be diluted. Too much secretion of antidiuretic hormone is sometimes called the syndrome of inappropriate antidiuretic hormone, or SIADH. And so therefore one of the issue or one of the problem with patient having SIADH is that they can retain too much water and they will not be being that much. So as a nurse, one of our main responsibility if we're taking care of a patient diagnosed with SIADH is to make sure that we restrict the fluid intake of the patient because the patient doesn't need additional fluid intake since the patient's already retaining too much water secondary to an increased secretion of vasopressin or antidiuretic hormone. Now, on the flip side, if you don't have adequate secretion of antidiuretic hormone, then what will happen is the patient will be peeing a lot. The patient can be drinking gallons and gallons of water, and the patient won't be able to retain any of them because the patient is not secreting adequate amount of antidiuretic hormone. Patient will drink, pee, drink, pee, drink, pee. This condition is what we call diabetes insipidus. So patient with diabetes insipidus doesn't have enough secretion of antidiuretic hormone or vasopressin. So patient will be susceptible to dehydration, and the patient will be excreting large volume of urine with a specific gravity less than 1.010. Okay. Oxytocin. Oh, by the way, for diabetes insipidus, then your main responsibility, if you're taking care of this patient, is to make sure that the patient will not go into hypovolemia that can lead to hypovolemic shock. Um, so your main concern would be the the fluid intake of the patient. You must increase the fluid intake of the patient and make sure that the patient will be given a diet high in sodium in order to help the patient reabsorb additional sodium. Hopefully, that can help retain some water. So in terms of the IV fluid that will be indicated for patient with diabetes insipidus, then you have to choose an IV fluid that has adequate amount of sodium in it, like zero point 0.9 NaCl or sodium chloride, um, or even lactated ringers, because it helps in keeping. In fact, lactated ringers has more sodium than zero point 0.9 NaCl. But you have to consider the other, electrolytes as well. Now, the other hormone secreted by the posterior pituitary gland is the love hormone or the oxytocin. The love hormone target organ will be the mammary glands and, of course, the uterine muscles. If you remember earlier, we talked about prolactin that helps in production of milk. But for the oxytocin doesn't help in the production of milk, but rather it helps in the letdown reflex. So, production of milk is the responsibility of prolactin, whereas the letdown reflex is the responsibility of oxytocin. And of course, the contraction of the muscles, uterine muscles rather, during labor and delivery. So, again, in summary, pituitary hormones, you have 7 hormones from anterior pituitary gland and 2 hormones from the posterior pituitary. All right, sorry. Um, I have some questions here, or sample questions that might help you with with your NCLEX. And let's try to answer these questions, and we will try to dissect all the options and all the elements of the questions. All right. So, question number one. While reviewing endocrine hormones with classmates, you review that a stature disorder in which the body produces too much or too little growth hormone is a disorder of which endocrine gland. So, a stature disorder in which the body produces too much or too little growth hormone is a disorder of which endocrine gland. So, growth hormone again is released by, you're right, the anterior pituitary gland. So the answer would be A. because growth hormone or somatostatin or somatotropin is actually released by the anterior pituitary gland. Good. All right, number two. A patient on the floor is complaining of decreased urination. The physician has diagnosed this patient with a disorder of the posterior pituitary gland. Which hormone is most likely responsible for this decreased urination? So, again, we talked about this just a few minutes ago. The urine output or the urine production uh, and water retention is actually governed by a hormone from the posterior pituitary gland called vasopressin, which is sometimes called as the, yes, of course, it's the ADH or the antidiuretic hormone. So if the patient is not urinating a lot, then most likely the patient is having too much secretion of antidiuretic hormone that can lead to a condition called SIADH or syndrome of inappropriate antidiuretic hormone. Next, a patient with bronchogenic carcinoma develops syndrome of inappropriate antidiuretic hormone. The nurse would expect the patient to exhibit. So again, SIADH, you have too much secretion of antidiuretic hormone. If I have too much secretion of ADH, will I pee or I will not pee? Yes, you might. A patient with SIADH will not produce adequate amount of urine because the patient will try to retain all the water. So patient will have oliguria, decreased urine output, and the urine will be concentrated, causing an increase in the specific gravity. Now, if you retain water, then it will cause dilution of the blood, leading to what we call hemodilution. And because of this dilution, it will cause hyponatremia, uh, which is basically caused by uh, too much water in the blood. This is what we call delusional hyponatremia. So the best answer here would be B. It will be hyponatremia with decreased urine output. And what's wrong with A? Hyponatremia with increased urinary output. This will be more associated with diabetes insipidus, where the patient cannot retain water, so the patient will be dehydrated, causing concentrated blood, leading to hypernatremia. Polydipsia and decreased urine specific gravity. Polydipsia or increased thirst and decreased urine specific gravity is also associated with diabetes insipidus. And instead of dehydration and hypovolemic shock, most likely patient with SIADH will have an increased intravascular blood volume that can lead to fluid retention and probably edema as well. Number four, a patient was admitted to the hospital to have a pituitary tumor removed. After surgery, she developed diabetes insipidus, a common complication of this surgery. The nurse should expect to administer which drug to treat diabetes insipidus. Diabetes insipidus is a condition where the patient doesn't have enough secretion of antidiuretic hormone, and so therefore the patient should be given exogenous supply of antidiuretic hormone in the form of pitocin or vasopressin. You wouldn't give Lasix to this patient because the patient is already having too much urine output, and regular insulin will not help the patient in this situation, and dextrose 10% water will not help the patient. So you need antidiuretic hormone or exogenous supply of vasopressin. Last question. The client just diagnosed with acromegaly is scheduled for a hypophyseectomy. Hypophyseectomy, let's dissect that word, hypophysis. Hypophysis is your pituitary gland. Therefore, hypophyseectomy means removal of the pituitary gland. Which statement made by the client indicates a need for clarification regarding this statement? Acromegaly is a condition where, again, the patient has oversecretion of the growth hormone after the closure of epiphyseal line or epiphyseal plate. Um, if the condition happens during adulthood, which normally uh, it is, um, then the bones will not return to its normal size or normal condition anymore. So the impact of this would be permanent. And so the patient, the question says which statement made by the client indicates a need for clarification. Well, then you need to make sure that the patient understand that the condition or the impact or the side effect rather of the condition will be permanent, and so the patient will not be able to go back to wearing size 8 if she's or he's wearing size 12 right now, because again, the bones will not go back to a smaller size since the impact is permanent. Okay, so that's all I have for you today, and I hope that you were able to review some of this. I will be posting some more videos um, about medical surgical nursing, and we will try to introduce some questions so that or NCLEX questions that you can analyze, so that hopefully it will help you uh, understand some of these concepts and some of these disorders, and help you prepare for your NCLEX exam. So again, thank you very much, and see you next time. Thanks.